My name is Ann Jensen, and I am the pilot project manager for Site 10, which is the city of San Diego. And our community paramedic pilot falls under the Resource Access Program, or the RAP program. And a RAP is actually a partnership, and our pilot as well as a partnership between AMR and San Diego Fire Rescue. We contribute equally to the project. And our RAP mission is to address the needs of vulnerable EMS patients and preserve safety net resources. We consider ourselves the strategic social arm of fire and EMS, and in San Diego, we're very much a desirable spot. If you Google the best places to be homeless in the United States, San Diego pops up. And so we have a lot of social issues that we deal with. So unlike Alameda, we don't exist on an island. We get people arriving by bus every day who want to live in San Diego. So we have 1,350 people in the city of San Diego that are considered frequent 911 callers, and that number is up from 2010. The program was established formally in 2010. It existed as a pilot project in 2008 before that, but at that time we had 1,170 frequent users. So it's gone up from 0.08% of the population to now 0.1% of residents in San Diego generate 11.4% of EMS calls. But what we do know is that when we implemented the program, that was almost 20%. So we have seen a decrease in the number of calls generated by frequent users. The cost of our frequent user population per year is about 10 million, and when we get into the cost, we're looking more at 20 to 25 million charges when we talk about charges. And within that group, there's a high prevalence of vulnerability, and so 65% of our frequent 911 callers are experiencing some form of mental illness, 40% are homeless, 35% are elderly, and 33% are dealing with some kind of addiction. And those are the groups that we most target. And we joined the pilot program not because we were enthusiastic about reforming healthcare. That really wasn't our mission. We saw it as an opportunity to put extra tools in our toolbox. We consider ourselves a public safety-based community paramedic program. And this slide, it's a little boring, and I'm going to talk about it for a long time. Community paramedicine is a little abstract, so I tend to have to use a lot of words I'm not articulate in describing, but some of this will speak to what Dr. Backer talked about this morning and other things. And that is why community paramedics are a good fit for these types of programs. I think we would do ourselves a disservice to brand ourselves as just cheap healthcare, because that's not the reason that paramedics are good for these roles. When we look at EMS and the EMS agenda for the future, and everybody pretty much agrees that EMS is the intersection between public safety, public health, and healthcare. And the EMS skill set reflects that. So, our paramedics come on scene and we can de-escalate a crowd and provide medical care at the same time. So when we have people and other pilots talking about, they're the only ones that go into that neighborhood to check up on patients, that's because there's a public safety issue interlapping with a healthcare issue. So what we find, community paramedicine is no different. So when we look at the state categories for community paramedicine, they all lean one way or another. And we understand that there's a healthcare component, of course, to our program. But when I say we are a public safety-based community paramedic program, really what I mean is that's our motive. So community paramedicine is also reflective of this intersection, but I would argue that there are more systems involved in this triad, and that would be housing, transportation, other forms of human services. And and I think that's what we're finding a lot with our pilot. We didn't anticipate so many public safety issues. So just 2 days ago, our paramedics come into a frequent user who's got 70 calls for the year, and he has a loaded gun on the seat next to him. Or a few months ago, and also I would note that there is such a thing as a black cloud in community paramedicine. This is not something we anticipated either. But the same medic had a patient call him. It was a pilot enrolled individual who called him a few months ago and said, I have a gun to my head, and tried to talk me out of it, that kind of conversation. So what ended up, we activated, obviously, a law enforcement response. And when he had heard that, he claimed he would shoot any police officer that came through the door. He only wanted paramedics. And what happened was we have our community paramedic who is pulled in as a third-party negotiator in a standoff situation, a barricaded standoff. And instead of doing the negotiation themselves, they pulled our medic in because they knew the house. He knew the names of the dogs. He knew the girlfriends, the family members' names, and he had relationships with all of those. So after that, we actually were approached by the crisis negotiation team who would like to bring us into their operation because we found that we have about a 40% overlap in patients, not the ones who jump from bridges, but the ones who are barricaded. And we have the potential to help them with some of the social issues of identifying and giving them something to talk about to stall. So, there really is an overlap. And the tools of the community paramedic reach even further into these boxes than the 911 paramedic. So that's kind of how we see it here. So since our program did exist before the pilot program, I wanted to make sure that people knew the difference. So everything in black is the traditional, and things in red are the pilot enhanced program. Under the traditional program, because it's not allowed in our scope of practice, we never identified ourselves as a paramedic, which presented limitations when caring for a patient. We only addressed social issues, and we really just provided navigation and education. But under the pilot, we're able to identify ourselves as a paramedic or a community paramedic, and we can address the medical and social issues at the same time, which is really important. At the time, before the pilot, we had officers who would pick somebody up from the ER, and they'd have their medication, and they'd give them one pill and put the medication in their pocket and say, I'll be back tomorrow to pick you up to take you to treatment so you can have the rest of your prescription then. So we had officers that were doing things like that because there was no care provider that could do that. And so this gives us the opportunity, not that we would do it that way, but this gives us the opportunity to also address medication issues and provide care as well as navigation and education. Is the volume still okay? Yeah, okay. So there was a question earlier about whether you were enrolling people in multiple studies, and our pilot project is when we submitted our proposal to OSHPD, to Lou, we proposed to do all of them, but all of them under the category of frequent user management. So we do we do have protocols related to all of these, but it's all being reported under frequent user management. And what we're doing, so alternate destinations, alternate resources, post-discharge follow-up, and care for chronic conditions. And what this does for us is it allows us to address a population that we couldn't address before. And I'll go down the list and I'll give you some examples of these. But so this really helped with addressing people who use EMS as a primary coping method. And an example of this would be the guy who gets discharged from the hospital. A taxi takes him home. He can't get his key in the door. And so he calls 911. We take him back to the hospital because that's his reset button. Another guy we had, and this was pre-pilot, was a guy who would have a bad dream. He was homeless. He'd have a bad dream. He'd call from a payphone and request an ambulance. He'd go to the hospital. He'd get discharged, and then he'd spend 4 hours walking back to get to that same payphone. He'd pass 20 other payphones, but he'd get to that one, and then he'd pick up the phone and call 911 again. And this was actually so I'm getting to the difference in how we used to handle things then and how we handle things now. But this guy, we caught him one day calling 911, and we said, put the phone down. And I had an officer with me, and there was a health clinic across the street. So we took him to the health clinic across the street, and we said, okay, next time you have a bad dream, come in here and ask them if you should call 911, and they'll and then they'll do that for you. And so we were introducing him to the staff, and we just got preoccupied, and he slipped out and called 911 while we were talking to the clinic. And so the sergeant that was with me said, "That's it. Like, we're shutting this phone down." So he calls the city, and the city shuts the payphone down. that was our old strategy in dealing with this. And what happened the next day was he went to the phone, he picked it up, it was dead. And so he put it back down and he walked over to the clinic and he said, "Can I use your phone?" And they said, "No, why don't you sit down? You know, things are okay. You'll feel better if you sit down." So he sat down and there was a television in the lobby. And he started watching television, and he never left that television except when they closed. And they were nice enough to let him in, so he would wait by the door. They opened the door. He'd watch television all day, and then he would leave when they closed. And so what we did during that time is we found him housing, and then we went to a thrift store and we bought him a television. And he, eventually we transitioned him to a care facility. But so this pilot also helps us address people who call for prescription refills. So if they need a prescription refill, then we can help them with that. And I'll show you the kind of our protocols later that are designed to let us do that. People who manipulate the system intentionally, and so this is another example of a senior citizen who lived in a city next to us, and he used his senior citizen discount to take the bus in, and he loved this bike. It was an $1,100 bike, and he wanted to go see it every day. And after that, he'd call 911, and then our medics would transport him to the hospital, and as soon as they opened the back doors, he'd jump out and run to his favorite taco shop. And they have very good tacos there, so we do understand this a little bit, but he would order a couple burritos, call 911, our medics would show up, and he'd say, "I need to go to this hospital, do you want a burrito?" And just a really nice guy, but he would take the ambulance to the hospital that was towards the east of his county, east of where he lived, and take the bus from there. And so, these are the kinds of patients that we couldn't address before. Like, what do you do with a guy like that when you have no legal ability to do anything other than take them to the hospital? So if 911 calls conflict with a primary care goal, this would be the psychiatric patient who goes to the ER 3 times a day, gets different medications from every physician she sees, and her primary psychiatrist can't keep her on a stable medication schedule. A serial inebriation without any acute medical conditions, people who are better served by a non-ED facility, repetitive, and then we get into like what we, those memes like what I think I'm doing, what my friends think I'm doing, and what we're really doing. This is actually like what we think we're going to do is the medical patients. So we do have some of the very unstable medical patients that we address. So, and I I kind of emailed back and forth with Lou and Dr. Kaufman about whether I should stay qualitative or quantitative, and we decided on qualitative. So I wanted to describe our model, our operation, and some of the philosophy that underlies it. So our first step is really identifying individuals, and we do that through system surveillance. And we do that through data mining and big data techniques, because we have patient care reports that are coming in, every few minutes in our system, and it's too much for us to analyze, manually. So we use computer algorithms to do that. We use a little bit of data mining, and data mining is a term that's not synonymous with data analysis. It's more predictive analytics, although a very simplified version. We deal in tree classifications and things like that. And then we know there are people who are less noticeable, but also equally vulnerable, and we look at that through crowdsourcing, where every firefighter and every medic in the system has a tablet that they can make a referral, and they leave a comment. So if we have somebody who's calling 20 times a month, which would probably not be in our top 30 patients. So if somebody is calling 20 times a month, we can look at a comment from each provider that's ever had contact and say, okay, well, he won't go to a shelter because he's got a dog and they won't let his dog in, and we can kind of, so in a way it's just crowdsourcing from the whole field. But this is the dashboard that they see. They come in, the medics come in, and they log in and they see our top callers, and this is updated in near real time, so you can see people as they race to become the top user in the system. So once we identify someone, we do a little bit of background, and each patient has a page that's automatically populated to show a summary of what's going on with them. So that would be an example. And then when we want to engage them, we have two avenues to engage them. And one is to go find them, not during a call. And for homeless people, it's often hard to find them, so we look at a map that we have that shows us where they've been, and often we find people that way. And we can also subscribe to an alert, so the next time they call 911, then we get a text or email to say they're in play right now. And that fits into our overall case management method. And this is, I've put in red where the pilot program components fit into each cycle in this, but I'll go over this quickly. First, we engage someone, and that is making them receptive to our care. We explain our intentions. The line that we use is, the paramedics were worried about you, and they asked if we could check up on you, and people love that. So we tell them that, we tell them what the program is, and then we try to enroll them at that time. After enrollment in the pilot, we take them to a meeting that we have once a week with the medical directors and the community paramedics. And we review their new enrollments, and we look at their past medical history, and we figure out which of those protocols they're eligible for, and under what vital signs and what circumstances can that protocol be deployed. And when we record it, it looks like this on the right. And we don't do any pilot intervention unless it's already been reviewed by the physician and approved by it, and then we write it into the care plan, and those care plans are stored electronically. So when they come into play, all you have to do, you get the alert, you log in, you look at the care plan, and you can deploy it. We do that. We make contact with the physician first. We wanted that physician bookend because it was a new concept. We were being ultra conservative. And I do think there is room to relax on this in the future. And it would probably be beneficial to relax on this. And I think the takeaway is that we shouldn't underestimate the role that technology can play in mitigating risk. Having stored case plans and shooting them in the right direction to the right caretakers, it allows us to provide care that's personalized rather than a protocol that's built to, work for 1.5 million people. So there's a difference there. So after they're approved for certain interventions, the next step for frequent users is usually stabilization. And if you look at we're dealing mostly with people in crisis and who are frequent users. And a crisis isn't an emergency, and a crisis is this perception that they don't have the resources to cope with the situation. So stabilization for us, really, when you go back to Maslow's hierarchy of needs, where the physiological needs and, things like that. So if somebody is severely addicted and they're going through withdrawals, or they're high, or they're suicidal, it could be a lot of things. Those are things that you have to address before you provide any education or anything else. And the author George Bernard Shaw once wrote, "I can't talk religion to a man with bodily hunger in his eyes." These are not patients that you can reason with. They will appear to be very resistant to services and resistant to change. And that is usually because they've got a logic and emotional imbalance. Their emotions are overruling. So what we work to do in the stabilization zone is to take the pain away, take that emotion away, and then when they're at an appropriate level of those two being able to compete with each other the way they do, in our minds, then we can talk education with them. So during the stabilization resource, a lot of times, not a lot of times, sometimes it's the alternate destination protocol that will get that person to the right facility. We find that if we always transport to an ER, the ER discharges them. We see this with our chronic alcoholics who go 3 times a day. They show up in the ER, they're completely drunk. That person sobers up a little bit. He can walk, he elopes from the emergency room, and then he goes back to drinking, and then he's back in the ER again. And so once he's in that loop, we try to, if we can get them to the right facility, either after the ER or before, if it's medically appropriate, then we have a better chance of stabilizing them. And during that stabilization period, we'll be looking at what resources we're going to connect them with. And that is where the post-discharge follow-up comes into play. And then once we connect them to the resource, they've transitioned there, then we support them. And these are, this is where it really requires a good knowledge of culture, especially in different socioeconomic states for a patient, and understanding that the things that we ask them to do sometimes are big sacrifices for them. This is probably this is the area, the support area, where the craft of the community paramedic really comes out, the motivational interviewing that every community paramedic here learned in school, and other things like that. And then once we get to the point where we think like, okay, we can ease back on this one, then we just watch them electronically. The next time they call, then we pretty much know that they've fallen off the wagon, and so we'll do this process all over again. And the nature of frequent 911 use is that you never just go through once and you stop. You go through this multiple times, and the key is to slow it down until it slows down, until they're only calling twice a year or so. And that's the model we work off of. We plan on relapses, and I think I gave enough case examples. That was going to be my case example. But I wanted to also provide my contact information, and also our community paramedic team main contact line. So if you're a community paramedic, you can feel free to email them if you want to get in touch with them, and then my email is here as well.
That looks different. So I just have to say, you don't want to tick Lou off. That's all I want to say, because he'll make you follow Ann. And I was really impressed. But let's contrast a big city program with a little city program. But I will say that we have the same, I think, goals at heart, which is we have, before I get into the program, we have our population in the city of Alameda, again, 79,000 folks. And as a small community, the way we operate, and Armando can attest to this, we know these folks. We know them because we go to them every day, or I should say our fire department goes to them every day, and those paramedics online. And so, for example, Carl Smart is one of our regulars, and, I would say he was one of our regulars. May he rest in peace. We try to help who we can, and we do the best that we can. But sometimes that's as much as we can do. Now, you can see two of our community paramedics, and they're actually out to work that day. This is a number of months ago, and they were meeting with Carl, as they often did, to try and help him through his day, and ultimately off to resources. And we did have some success with Carl for a while. And then ultimately, we did what we could. I do want to follow up on something that Ann mentioned, because here's a picture, and you've seen these slides before, but here's a picture of our R5 community paramedics, and two of them are TAC medics. So they actually work in our tactical medicine program as well. So these folks are used to working in unstable environments, I might say, and as a lot of the fire service personnel can attest to, we know that sometimes we go into those situations, and I know Ann mentioned that. Our folks, and in the case of this group of 5, pretty much know our clients, and I'm going to talk about the clients a little more in a minute. And as before, we're going to talk about why we're in it. So we had looked at our baseline initially, and we know that we're a small community, but we still have a lot of folks that come through, just as everyone does, because we have the folks that are the super users. And I think in all of our communities, we recognize that a small number of folks utilize the resources most of the time, and that I would say that we're not any different. So we have a number of folks that are use the service often. And as you can see in one case, and this is all baseline numbers, but we had 11, and this is countywide, but a number of those folks are in our community. We had 11 folks that used it more than 100 times in 1 year. Now, that isn't quite as bad as I think the gentleman earlier said that there were some folks that used it more than 400 times in a year. Oh, I don't know. These got a little... Somehow we got, and this is my fault, Lou. I appreciate your work on this. Somehow we got our presentation a little off keister here, but anyway, that is Steph Curry, and that is a success story. So what we've recognized. So anyway, I want to move on to a couple of things that I want to talk about, and as these slides in the background, and I don't really know how they got a little off track here, because this is actually I don't know exactly what happened in the presentation, but I will say that in our community, when we started in the program, one of our, and I mentioned earlier, our goals was to help the folks in the community. I've worked in the fire service for a number of years, and I worked online for a very long time, and I recognized that what I was doing was I was going on the same people a lot, and I didn't seem to be making much of a difference. And from my point of view, just me personally, the type of person I am, it really bothered me. I didn't like that I, did the same thing and expected to get a different result. So we really wanted to get involved in the programs that the domains that we're involved in. We had a goal to be involved in those. Familiar faces is, I think, a really important aspect of community paramedicine that we need to figure out a solution for, because we have folks out there, and when you start asking some questions in roundtable, you're going to find, if you question Armando, we have some folks out there that our hearts go out to. We oftentimes go on them and we just can't quite reach them. I have a good friend who used to say, I feel for you, but I can't reach you, and oftentimes that's the way I felt, because we go out there and we can't quite get to them, and we're looking for solutions in that regard. And a lot of the things that Ann mentioned in a big city program, I'd love to see us be able to incorporate as well, because again, it's back to that collaborative model. But in our environment, we're working individually with these folks, and we're trying to, and you'll hear, we're trying to reach them one at a time. And we've had successes. We've had a few folks that we've moved into programs, and they've been successful with those programs. But oftentimes we feel like we're still hitting those same roadblocks, which is we're meeting with them, and as Dan will mention probably sometime when you question him, is we just can't quite seem to move them off of their area of comfort. But we're not going to quit on them, that's for sure. So with that, I think we're going to move into question and answers.
I just wanted to return to something that Dan mentioned earlier in an earlier panel, and I think it bears repeating, and I think everybody who's been working on a program like this should really keep it in mind, and that is that, at least in California, this is very much the early iteration of what we're trying to do with community paramedicine programs. And you hear all the time that we have the greatest healthcare system in the world, and those of us who work in healthcare, any role in a healthcare environment, know that in many ways it's not really a system. And I think that what Alameda City is trying to do, and San Diego, and all the other programs that we have seen today, is we're trying to move some sort of a solution forward. And I don't think it really matters at the end of this whole pilot project whether a couple of domains worked much better than others, or we find out that it's going to be cost neutral, or it's going to cost more than we bring in, or we make money on it. I don't really think any of that matters. I think the important thing to keep in mind is that we've tried something here. And I would also say that in the early stages of putting these things together, at least in my experience in Alameda County, there were a lot of challenges that had to be overcome, like Rick mentioned. And all anybody has to do is actually go out and do a ride-along with the community paramedics one day to see that, what they're doing is addressing a need that exists. And so I just want to commend all of you and everybody in the room really who have worked on these programs, because we have to try something. We really do. We can't just keep letting things go as they always have.
I'd like to make a comment on Fred's comment there, if I'm. So, in our city, in our what we're working on in the 2 domains, but in familiar faces, we're making a difference. I mean, we've had reductions in our baseline populations utilization of the system. Actually, it's down 47%. But the problem is that's not good enough, and there are people that are falling through the cracks, and there are people that, with all of our best efforts, we're just not getting it done. So we have to keep working. We have to work harder, and we have to find a solution, because that's our job.
I'm here from San Diego County as well, Lakeside, unincorporated San Diego. San Diego has 18 cities that make up, I'd have to guess, but maybe a quarter of the actual land area of San Diego. So those cities have social services built into them, but the bulk of EMS is run outside of those cities. So what we lack as EMS providers is the contacts to a structured city with social services. The social services have to go through county resources. So I'm curious if there are any models or if there was anything done to look at building those partnerships outside of the city structure. So with us, that would be with our county social services, with the various hospital districts that serve all of our areas. I think it's just, that's one of the hurdles we would overcome. And we have a tremendous homeless population in our county because, like you said, it's 76 and sunny every day, so why not move here? It's challenging for us because we don't have the social structure that goes along with the homeless problem, which is our repeat 911 offenders for the most part. I'm just curious if you ran into those problems as well.
Well, in our program, and I'll let Armando speak to this directly, but in our program right now, we're like at the nascent stages of trying to cobble together what an organized system looks like. And I'll let Armando speak directly to that, but Armando and the community paramedics are building relationships right now. And then hopefully from that point we could build out. But go ahead, Armando, tell them just some of the things that you have to deal with.
Yeah, right. Yeah, you have to be really creative. A lot of our resources are not, we don't have a lot of resources in Alameda. So we have to go outside our city to go find those resources. And that's where you got to do a lot of legwork. You have to go knocking on doors, setting up meetings and meeting with the intake coordinators or the program administrators. And you got to let them know what you need from them and how they could fit in that whole program. We did a ride-along with Captain Tangerlini in San Francisco, and he used to run a program out there several years back. And the one thing I learned, he basically ran a program where he was trying to help homeless and folks that were inebriates, substance abuse. And that day trip, I learned that you have to be really persistent, and you have to make calls. You have to establish these relationships with, they had a detox center, they had a social detox center. You have to collaborate with everybody because there's a process in, for example, San Francisco, there was a process in how to get a client into medical detox. And if you didn't know that, if you just kind of called and try to get someone into medical detox that day, you wouldn't be successful at it. You got to kind of plan for it ahead of time. And so what we're doing is we're going out and meeting these folks that run a substance abuse center, for example, and figure out what is it that we need to do to get our client in, because you only have a short window with most of these folks. You first of all, you don't know where they are every day. And you don't know if they're really able or what's the word, willing to go. You have to catch them at their weakest point, and when you do, you got to be ready to go. So the trick is to get your plan ready so that when that situation arises, you're ready to go, and you just have to do the legwork. Now, it's not a perfect system, and I think the solution or a direction towards a solution is to, when you do your community assessment, not just look in the phone book and see who handles this or that, but identify those people and get everyone in the room. And that's something we still need to do, but it's hard to do. I mean, we're talking maybe 10 agencies or associations that need to get involved and be in that room and figure out how are we going to deal with, because there should be no excuse for someone being homeless or getting medical detox or getting treated. I mean, we live in America. I mean, we shouldn't have to deal with this. And the solution's there. You just have to do the legwork. It's getting everybody together.
And I'll echo that if I could. It's for our community paramedics. It's no easy task. There's a lot of legwork involved, and I think there's a little bit of something that has to happen in the mind of the community paramedic to feel that empowerment to go do that. You can't accept services for what they are, and I think in the future, as we become stronger in community paramedicine, then we will hopefully have some kind of policy building that we can do in our, welfare, some influence on our welfare and institution codes and things like that, and that will come in time. But I think to be most effective, you have to do the legwork, but then you also have to have the skill of building resources, which is difficult. But we should touch bases after, because you're close to us, and I think there are probably a lot of services that you could benefit from.
And if I could, there's just 2 points I want to make. One has to do with what Armando said. We really didn't do a full-scale needs assessment before implementation of the program. And I think that if we had everybody at the table, we could have leveraged we could have got agreements and understanding amongst everybody how it should work. And at the same time, they also may have been able to provide the program tools that were within the paramedic scope of practice that we would have been able to leverage to be more successful. Like right now, we're kind of feeling our way around in the dark. One of the things you mentioned, though, you made an interesting comment about the homeless population. You can't think about frequent users as being homeless. And I'll give you an example. So Sue and Keon wrote a paper for CMS, and they said that 50% of all the healthcare dollars spent, 50% of all the healthcare dollars spent is spent by 5% of the patients. Okay? Now think about that. 5% of the patients, something like 19% of the patients account for like 92 or 93% of all the healthcare dollars spent. If you're in Camden, New Jersey, it's 3% of all the patients account for 50% of all the healthcare dollars spent. We say, well, that's CMS, those are Medicare and Medicaid patients. Dignity Health Systems, CalPERS report about 2 years ago, 8.17% of the patients account for 75% of the healthcare dollars spent for Dignity Healthcare. Now think about it. Those are all people with jobs, and those are all people with good health insurance. All right? And they account for 75% of all the dollars spent. When we talk about the GDP for healthcare, 30% by 2035, 30% of all the money spent for the gross domestic product in the United States is going to be spent on healthcare. By 2065, 1 out of every 3 people employed are going to be a healthcare worker. So that means the other 2 guys are patients, right? I mean, if 1 out of 3 is a doctor or a nurse or a paramedic or somebody, then everybody else is a patient. So, we really, don't get me wrong. The homeless are a vulnerable population, all right? They don't have a voice. We have to stand up for them. But the implications for what we do have a greater import on healthcare down the road, then we just can't have tunnel vision and we can't look at this with blinders. I'm sorry, I didn't mean them up.
Okay. we're going to have to move on to our next panel, but you have contact information for these folks, and I would not hesitate to reach out to them. And again, thank you very much.